I want you to close your eyes for a second. I mean, unless you're driving, of course.
Right. Please keep your eyes on the road.
Yeah, safety first. But if you can, I want you to visualize a stretcher. Just, conjure up that image in your mind.
Okay.
What is the very first thing you see? Like, if you are like most people, your brain immediately fills in the background with flashing red and blue lights.
Oh, completely.
You hear the screaming, high-pitched wail of sirens bouncing off city buildings. You picture paramedics rushing, shouting over the noise, moving with that frantic life-or-death adrenaline.
Yeah, we are completely conditioned by, decades of television, movies, and just the ambient noise of urban life to associate the very concept of a stretcher with acute trauma.
Exactly.
With a panicked race against the clock.
Mm-hmm.
It is a deeply ingrained visual reflex. Like we see a stretcher, we immediately assume crisis, trauma, and the emergency medical system swinging into full gear.
Right, but today we are dismantling that association completely. We're looking at a paradigm shift here.
Yeah, a big one.
The core focus of this deep dive is an entire logistical ecosystem that operates quietly every single day right alongside us on the highway, entirely without the sirens and without the flashing lights.
It's completely invisible to most people.
It really is.
Yeah.
We are looking at non-emergency stretcher transportation. And the mission here is to explore this profound logistical puzzle. Like, what happens when a human being is perfectly medically stable?
Right.
No active cardiac event, no stroke, no collapsing airway, but their physical body simply cannot withstand the forces of gravity required to sit up in a seat.
It is basically a structural engineering problem applied to human biology.
Oh, I like that way of putting it.
Yeah, because when you remove the emergency aspect, the ticking clock of a 911 call, you are left with the raw physical reality of transporting a fragile, horizontal human body through an infrastructure that is exclusively built for people who can walk.
Right.
Or at least, bend at the waist.
Okay, let's unpack this. Because understanding this hidden logistics network is crucial for you, the listener, whether you are a patient, a caregiver, or simply someone who will inevitably have to navigate the friction-heavy machinery of the healthcare system on behalf of a loved one.
And you will eventually. Everyone does.
Exactly. Knowing the architecture of the system before you are in a hospital room desperately trying to solve it, it can save you an immense amount of systemic friction, prevent devastating physical injuries, and fundamentally preserve dignity.
To really understand this, we have to establish the boundary lines first. The non-emergency medical transportation sector, or NEMT, draws a very hard line in the sand regarding what constitutes an emergency.
Right.
It all hinges on the clinical definition of medical stability.
Yeah, I was looking at the triage guidelines on this, and the distinction between an NEMT stretcher van and an ambulance is entirely about the level of active, dynamic medical care required during the transit itself.
Precisely.
Like, an ambulance is essentially a mobile intensive care unit.
Yeah, it's an ICU on wheels.
Right, and you require that mobile ICU if you need active cardiac monitoring or continuous oxygen titration that goes beyond just, a baseline nasal cannula, or if you need a paramedic to push intravenous medications en route.
And medical stability is a concept that is often profoundly misunderstood by the general public.
How so?
Well, stability does not mean the patient is healthy or strong or even pain-free. Stability simply means predictability.
Predictability. Okay.
Right. Okay. It means that the patient's current physiological state, however fragile or compromised it might be, has flatlined in a predictable manner.
Got it.
They're not actively deteriorating. Their vital signs are holding steady without continuous clinical intervention.
It makes me think of an analogy. It is the difference between hiring a highly specialized, climate-controlled moving service for a priceless, centuries-old, incredibly fragile painting.
Okay, I see where you're going with this.
Versus calling the fire department because the museum is actively burning down.
Yes.
Like, the moving service is going to handle that painting with incredible mechanical care, using the right kinetic straps and suspension systems to prevent the canvas from tearing. But they are absolutely not equipped to extinguish a sudden fire.
That analogy perfectly isolates the mechanical versus clinical dynamic.
Right.
The movers protect the fragile item from the environment during transit. The firefighters stop the item from being consumed by an active threat.
Exactly.
So if a patient exhibits any of the classic emergency indicators,
Like what?
Acute chest pain, sudden aphasia or signs of stroke, severe uncontrolled bleeding, or a rapid drop in oxygen and saturation, The lying down aspect of the stretcher becomes secondary to the fact that they need advanced life support to keep their organs perfusing.
But wait, let me push back on that a little bit.
Sure.
If someone is so physically compromised that they require a specialized stretcher and a two-person lift team just to travel across town for a wound care appointment, aren't they inherently at a higher risk of suddenly deteriorating? Returning to the analogy, isn't there always a latent fire risk in that museum?
This raises an important question, actually. There is always a baseline risk in medicine. But categorizing risk accurately is how the entire healthcare infrastructure avoids collapse.
Oh, okay. That makes sense.
Because if we dispatch an ALS ambulance, tying up a paramedic, an EMT, and a vehicle loaded with defibrillators and intubation gear merely to move a stable, bed-bound patient across town, we're severely degrading the 9/11 grid.
Oh, wow.
That ambulance is now unavailable when a pedestrian is struck by a vehicle 2 miles away.
Right. The stakes of that categorization are completely systemic. A misclassification drains the grid.
Exactly.
But on the flip side, using an NEMT stretcher van for a genuine emergency because the family, I don't know, maybe they didn't recognize the creeping signs of sepsis or because they were trying to avoid a massive ambulance bill is equally disastrous.
It's a fatal mistake.
Yeah.
Because the NEMT team does not have crash carts. They are trained in biomechanics and safe transport, not emergency resuscitation.
Right. So defining that line correctly requires a solid grasp of who actually utilizes this shadow network. These passengers are moving through our cities constantly, yet they remain largely invisible to the average driver.
They really do.
Instead of just listing off the demographics, let's trace the actual biological and logistical journey of a patient moving through this system.
I think that's the best way to visualize it.
Right. So think about the physical realities of severe post-surgical recovery. Let's look at a patient who has just undergone a massive L4-L5 spinal fusion or perhaps a complex pelvic reconstruction following a bad fall.
In those scenarios, the surgeon has literally manipulated bone, they've anchored hardware into the skeletal structure, and sutured deep tissue.
It's major, major trauma to the body.
Exactly. But the acute phase of that trauma is managed in the hospital. Once the risk of immediate postoperative hemorrhage or respiratory failure from the anesthesia has passed, the hospital considers the patient stabilized.
So the acute crisis is over, and the hospital initiates the discharge protocol. But the patient's body is still in the earliest, most vulnerable stages of deep tissue repair.
And this is where the biological reality clashes violently with logistical expectations.
Yeah.
Bending the human body at a 90-degree angle to sit in a wheelchair, or folding that body into the passenger seat of a standard sedan, places massive shear stress on the lumbar spine and the pelvis.
Oh, just picturing that hurts.
Right. Forcing a seated position could literally rip sutures, displace hardware, or compromise blood flow to the healing tissue.
Wait, if a patient is officially discharged from a hospital, why can't the hospital just, put them in a wheelchair and roll them to a regular medical van? Like, surely they have a ramp.
Well, because being cleared to leave and being able to sit are two entirely different medical realities.
Okay.
A wheelchair ramp doesn't solve the fact that the patient's spine cannot bear weight.
So the hospital hands the caregiver the discharge papers, essentially saying, the acute medical crisis is resolved. You no longer require a highly monitored telemetry bed.
Right.
But the patient's biomechanics are screaming, I cannot fight gravity and I absolutely cannot fold.
Imagine the sheer panic of a family member in that exact
It
moment.
must be terrifying.
It is. They are looking at their loved one, who might be heavily medicated, completely unable to recruit their core muscles to sit up. Then they look out the window at their compact car in the parking garage.
Yeah.
The gap between being administratively cleared to leave an acute facility and being physically capable of utilizing standard transportation is a chasm that families frequently fall into without any warning whatsoever.
And it's not just post-surgical patients, right? This journey encompasses a huge swath of the population.
Oh, absolutely. There are basically 7 core categories of passengers we were talking about here.
Right, let's go through them. Because we have post-surgical, obviously. Then we are talking about individuals who are permanently bedbound due to advanced neurodegenerative diseases like ALS.
Yes, where the muscular structure has degraded to the point where the torso cannot support its own weight.
So if you put them in a wheelchair, gravity simply pulls them forward.
Exactly, which compromises their airway and risks a severe fall. You also have patients with severe generalized weakness, people being discharged from long hospital stays who have lost all their muscle mass.
And then you have the interfacility transfers, right?
Yes, this is the continuous invisible flow of patients moving from acute care hospitals to specialized skilled nursing facilities.
Or from rehabilitation centers into long-term hospice care.
Precisely. You also have patients with specific injuries, like a fractured hip, where sitting is just agonizingly painful or medically unsafe.
Right.
And finally, you have comfort-based transport.
Wait, what does comfort-based transport mean? That sounds almost like a luxury, but I know it's not.
It's not a luxury at all. It refers to patients where forcing a seated position causes severe instability or distress. Maybe they have advanced dementia, and being strapped into a wheelchair causes intense panic, whereas lying down on a stretcher feels safer and calmer.
Wow, that makes total sense. Or even just the routine, repetitive transport for medically stable patients who simply need to access specialized outpatient care.
Right, going to a hyperbaric oxygen therapy session for a severe diabetic foot ulcer, or traveling to a specialized imaging center for a recumbent MRI.
They don't need a paramedic to hold their hand, but they absolutely must remain supine.
Yes, and knowing the extreme fragility of this demographic brings us to the core engineering problem of NEMT,
Which is,
the mechanics of the move itself.
oh yes.
Because moving a human body that cannot assist in its own transfer, while maintaining perfect spinal alignment and preventing shear stress on compromised skin, requires a level of physical choreography that is rarely appreciated.
I was struck by a specific realization while digging into the operational protocols of these transport companies.
What was that?
Well, here's where it gets really interesting. Driving the specialized van is arguably the least dangerous and least specialized part of the entire job.
It really is.
The absolute peak of vulnerability, the moment where catastrophic injury is most likely to occur, is the transfer. The literal movement of the patient from their bed across empty space and onto the transport stretcher.
Right, because if the transfer is done poorly, the passenger can be injured before the vehicle even leaves the driveway.
It sounds like these transport teams need to be part physicist, part nurse.
What's fascinating here is that you're not wrong. The transfer is a masterclass in applied physics.
Seriously.
You are dealing with a dynamic asymmetrical load.
A human
A
body.
human body, exactly, that often weighs upwards of 200 pounds. You cannot simply grab and pull.
Right, because think about a patient who is elderly with profoundly compromised skin integrity.
Yes.
If a transport technician applies direct horizontal drag across a bed sheet, the friction can cause skin tears or exacerbate decubitus ulcers.
Which can take months to heal, if they heal at all. It is entirely an engineering puzzle solved with human hands and specialized tools.
What kind of tools?
Well, they utilize friction-reducing slide boards, specialized draw sheets, and mechanical lifting techniques that prioritize weight distribution and structural support.
So it's not a job for someone who has only been trained to drive.
Oh, absolutely not.
Yeah.
The technicians have to synchronize their movements perfectly. They are often working in incredibly cramped environments, too.
Like a cluttered residential bedroom.
Yeah, or a narrow hospital room filled with IV poles and monitors and chairs. They have to calculate the precise angle of elevation, stabilize the patient's cervical spine, and execute a lateral transfer without dropping any limbs or compromising their own musculoskeletal health.
A driver who only knows how to navigate traffic will fail catastrophically at a slide board transfer.
100%. And the operational protocols also place a massive emphasis on infection control during these transfers.
Right, which goes far beyond just, throwing down a clean sheet.
It does. We are talking about the microbiological reality of moving highly vulnerable, often immunocompromised patients between different healthcare environments.
Because the stretcher itself is a high-contact medical device.
Exactly. When you are transporting a patient recovering from an open surgical wound, or someone carrying a healthcare-associated infection like MRSA or C. diff, the transport vehicle has the potential to become a rolling vector for disease.
That's terrifying to think about.
It is. Meticulous sanitation of the stretcher rails, the mattress seams, the kinetic securement straps. This is not about aesthetics. It's a fundamental pillar of medical safety.
Breaking the chain of infection requires rigorous, documented sterilization between every single transport.
Yes.
Okay, so assuming the physics of the transfer have been successfully navigated, the patient has been moved without skin shear, the slide board was used perfectly, and the stretcher is wheeled out and locked into the kinetic securement system in the back of the NEMT van.
Safely loaded.
Right. But the moment those rear doors close, the journey introduces a completely different phenomenological experience for the passenger.
A very intense one.
Yeah, we have to look at the psychology and the sensory reality of the ride itself.
The sensory experience of horizontal transit is profoundly disorienting.
Why is that?
Well, when you or I sit upright in a car, our bodies are naturally engaged in maintaining equilibrium. Our visual cortex registers the horizon, anticipating turns and stops.
We brace ourselves without even thinking about it.
Exactly. Our core muscles and our cervical spine act as biological shock absorbers, subconsciously bracing against the kinetic energy of the road.
But when you are strapped supine to a stretcher, staring straight up at the ceiling of a van, you are stripped of all of those biological defenses.
All of them. Your visual horizon is completely gone. Your vestibular system, your inner ear, is subjected to acceleration, deceleration, and lateral G-forces without any visual context to process them.
That sounds incredibly nauseating.
It is. And every single vibration of the chassis, every microscopic pothole, every expansion joint on a bridge transfers directly through the stretcher mattress and into the patient's skeletal structure.
It's like driving with a brim-filled cup of hot coffee on the dashboard. But the coffee is a vulnerable human being who feels every single bump.
That's a perfect way to describe it.
Oh.
If the driver applies the brakes too late at a red light, the deceleration force isn't absorbed by a seatbelt across a braced chest.
Right.
That kinetic energy travels laterally through the entire body. If the patient just had abdominal surgery or possesses a fractured pelvis, that sudden deceleration is a violently painful physical event.
So the defensive driving required here isn't just about avoiding collisions.
No, it is about micromanaging the kinetic environment of the passenger. It demands a complete recalibration of how the driver interacts with the vehicle's momentum.
They have to anticipate traffic flow blocks in advance.
Yes, feathering the brakes, taking turns at a crawl to minimize centrifugal force. They're not merely driving a vehicle, they're piloting a mobile recovery environment.
And that physical vulnerability is deeply intertwined with the psychological vulnerability of the passenger.
Oh, deeply.
Because the power dynamics of being strapped down horizontal while able-bodied strangers stand over you are inherently degrading if not managed with intense empathy.
The loss of agency is total. You are physically weak, you might be wearing a hospital gown, you may have catheters or drainage tubes present.
Right.
For an adult who has been autonomous their entire life, this sudden regression to total physical dependency can trigger massive spikes in cortisol and acute anxiety.
Feeling weak, feeling embarrassed, feeling like a burden.
Exactly.
The operational mandate for treating the passenger with dignity is fascinating to me because it's not framed as a customer service bonus. Like, it's not just a nice to have, it's framed as a clinical imperative.
It is a clinical imperative, treating the passenger as a person, not a task.
But how does a transport team actively preserve a patient's humanity when the process itself is so inherently clinical and awkward?
Well, it manifests in the micro-interactions. It means the technicians make eye contact and speak directly to the patient.
Rather than talking over them to the nurse or the caregiver as if the patient were just a piece of freight.
Exactly. It requires constant, preemptive communication. Saying things like, we're going to encounter a small bump as we cross the threshold into the elevator now, or I am going to adjust the incline of the backrest by 10 degrees to ease the pressure on your chest.
It is about restoring a tiny fraction of their autonomy by just keeping them informed.
Yes. It also means fiercely protecting their privacy, ensuring blankets are securely tucked so there is no unnecessary exposure while rolling through a crowded hospital lobby and maintaining absolute professionalism.
Never making jokes about their condition.
Never. Because the physiological response to indignity is measurable.
Wait, really?
Oh, absolutely. When a patient feels marginalized, rushed, or handled roughly, their autonomic nervous system reacts. Heart rates elevate, blood pressure spikes, and stress hormones flood the system. In a patient already managing a fragile medical baseline, that stress response actively delays healing and exacerbates pain. Dignity is an active medical intervention.
That is profound. Dignity as a medical intervention. Let's pull back from the interior of the transport van, though, and look at the macro level.
Okay, let's zoom out.
Because this incredibly nuanced, highly specialized service does not operate in a vacuum. It is the connective tissue of the entire healthcare ecosystem. The systemic impact of NEMT on hospital infrastructure and healthcare economics is massive.
To understand the systemic impact, you have to look at how hospitals actually function. A hospital is basically a flow system.
Right.
It is entirely dependent on the constant, predictable turnover of beds.
And the logistics of bed management are incredibly brittle. Like if a patient on the surgical ward is medically cleared for discharge at 10 a.m., but their specialized stretcher transport is delayed.
Or the dispatcher failed to realize the patient requires a bariatric stretcher and has to abort the trip.
Right, then that
Right.
patient remains in that bed.
And the cascading effect of that single delayed bed is immediate and severe.
How so?
Because that surgical bed is occupied, the post-op patient in the recovery room cannot be moved up. Because the recovery room is full, the operating room cannot accept the next surgical case.
Oh, man.
And simultaneously, down in the emergency department, patients who require admission to the surgical ward are held in ER beds.
Which means the ambulances pulling into the emergency bay cannot offload their critical patients because the ER has nowhere to put them.
Exactly. The paramedics are stuck waiting in the hallway. A single logistical failure by a NEMT provider at a discharge bed can literally back up the entire 9/11 grid of a city.
That is insane to think about.
It's a house of cards. This is why reliable, highly trained stretcher transport is not just a convenience for the family, it is a critical operational dependency for the hospital's administration.
It keeps the arteries of the healthcare system from suffering acute thrombosis.
Very well put.
But, the bottleneck often isn't the availability of the vans, right? The deepest friction point and the part that causes families the most profound anxiety is the financing maze.
Oh, the financing. Yes.
Let's delve into the bureaucracy of how this is actually paid for, specifically looking at the labyrinth of CMS, the Centers for Medicare and Medicaid Services.
The regulatory framework governing transport reimbursement is incredibly rigid, and largely as a historical response to massive systemic fraud in the late 1990s and early 2000s, where ambulance companies were aggressively billing Medicare for transporting perfectly mobile patients.
So CMS cracked down hard.
Very hard.
Now, Medicare Part B will generally only cover ambulance transportation if it is strictly deemed medically necessary.
And the language is extremely specific. The patient's condition must be such that using any other method of transportation would actively endanger their health.
So, what does this all mean? If a patient absolutely needs to lie down but doesn't need active medical monitoring, they fall into this gray area where Medicare might say no to an ambulance, leaving the family to figure it out.
If we connect this to the bigger picture, establishing that medical necessity requires navigating a gauntlet of documentation
Right.
for scheduled repetitive transports, like a bedbound patient needing to travel to an outpatient dialysis center 3 times a week, CMS requires a highly detailed physician certification statement.
And that has to be constantly updated, right?
Yes, this certification must be dated no earlier than 60 days before the service. It places a massive administrative burden on the referring physicians to constantly justify the physical immobility of patients whose underlying conditions, like advanced ALS or severe paralysis, are permanently irreversible.
That sounds incredibly frustrating.
It is. Now, Medicaid offers a bit more flexibility, but it is highly fragmented because it is administered at the state level.
Like, CMS gives states flexibilities to handle it how they want.
Exactly. New York, for example, utilizes a brokerage model managed by Medical Answering Services to coordinate NET.
But ultimately, if a patient doesn't meet the strict bureaucratic definition of medical necessity for an ambulance, and they don't qualify for state Medicaid programs, they fall into a massive financial gray area.
This is where the bureaucracy's definition of medical necessity violently collides with the physical reality of the patient.
Yeah.
The bureaucracy says, you do not require cardiac monitoring or intravenous medication, therefore an ambulance is not medically necessary. But the laws of physics state that the patient's spine cannot support a seated position.
So the family is forced to bridge that logistical gap with out-of-pocket private pay.
Yes. And this is a terrifying position for a caregiver to be in. They are suddenly thrust into the role of a logistics coordinator, tasked with vetting complex medical transport companies while simultaneously managing their loved one's recovery.
Which is why families navigating the private pay market need to be equipped with a rigorous framework for evaluating these providers, because private pay should never mean lower standards.
Exactly. Paying out of pocket must guarantee the highest standard of care, biomechanical expertise, and communication. It cannot mean settling for a disorganized company operating an unsterilized van.
So let's talk about how families can actively audit these providers before booking. It comes down to pre-trip communication.
100%.
The questions a dispatcher asks, or fails to ask, are the ultimate leading indicators of the company's competence.
Yes.
Like, if a family calls a transport provider and says, I need to move my father from the hospital to his home, and the dispatcher simply says, great, we'll be there at 2 p.m.
Without asking anything else.
Right. The family should immediately hang up the phone.
A frictionless booking process in this industry is a massive red flag.
It really is.
A competent NEMT operation will subject the caller to a rigorous intake interview.
What should they be asking?
They need to be asking highly specific environmental and clinical questions. What is the patient's exact weight to ensure the stretcher's hydraulic limits aren't exceeded?
Right, because bariatric stretchers are a whole different thing.
Exactly. Are there any specific orthopedic injuries or surgical sites that require modified securement? Are there any cognitive impairments, like advanced dementia, that would require specialized de-escalation training from the transport team?
And fundamentally, they must audit the physical environment of the destination.
This is so critical. Are there stairs?
Right, because extricating a horizontal human being on a stretcher down a flight of narrow residential stairs is a highly dangerous, technically demanding maneuver.
Very dangerous. If the transport team arrives completely unaware of a third-floor walk-up, they are either going to attempt a dangerous lift they aren't equipped for, or they will have to abort the transport entirely, sending the patient back to the hospital.
So the philosophy of a high-tier provider, like the SwiftAid transport standard detailed in the operational literature, views pre-trip coordination as the foundation of patient safety.
Yes. Their entire operational model is built on transparency, rigorous technician training in biomechanics, and viewing the transport not as a simple taxi ride, but as a critical continuation of the healthcare continuum.
That's a great way to put it.
Stretcher transportation is not just about moving someone lying down. It is about helping that person continue their healthcare journey safely.
Because poor pre-trip coordination causes a cascade of failures at the hospital discharge level.
Exactly. It is about acknowledging that access to care is synonymous with care itself.
Right.
If a patient is approved for the most advanced wound healing therapy in the state, but they suffer a shear injury to their skin during a botched transfer, or they are forced to miss the appointment entirely because the transport company failed to navigate the logistics.
Then that patient effectively has zero access to healthcare.
Precisely.
Well, we have covered a massive amount of ground today.
We really have.
We started by breaking down the deeply ingrained psychological reflex that links stretchers exclusively to 9/11 emergencies.
Dispelling the ambulance myth.
Yeah. We navigated the precise clinical definitions of medical stability, explored the intense biomechanics and physics of lateral transfers, and examined the profound phenomenological and psychological impacts of horizontal transit. Yeah.
And dignity as medicine.
Right. We also mapped out how these individual rides dictate the macro flow of hospital infrastructure and the intense bureaucratic maze families must navigate to secure this care.
It is an intricate, largely hidden ecosystem that underpins the functional reality of modern medicine. It relies on the silent labor of highly trained technicians who manage the physics of human fragility every single day.
So to you listening, you are now equipped to navigate this system. If you ever find yourself holding discharge papers, staring at a loved one whose body cannot fight gravity, you now understand the mechanics of the solution.
Yes.
You know the exact environmental and clinical details a transport dispatcher should be demanding, and you understand the absolute standard of dignity and physical safety you must enforce on behalf of your family.
Having the operational vocabulary to advocate for proper NEMT is a critical tool in modern caregiving.
But before we close out this deep dive, I want to leave you with a completely different angle to ponder. We've spent this time analyzing the specific logistics of moving a horizontal body through our current world. But think about the future of infrastructure. As we rapidly transition toward autonomous vehicles, smart cities, and hyper-efficient urban design, almost all of that architectural and engineering effort is based on a single assumption: the 90-degree seated or ambulatory human.
Oh, wow. Yeah, the entire future of mobility is being coded for the seated passenger.
Exactly. From the dimensions of autonomous rideshare pods to the standardized turning radiuses of modern residential hallways, the physical world is increasingly hostile to the horizontal human.
That is a staggering thought.
Right. If we don't actively engineer our future cities and vehicles to accommodate severe physical frailty, we risk permanently locking our most vulnerable populations out of the physical world entirely.
We spend so much time obsessing over the quality of the doctors, the surgeons, and the hospitals. But if transportation is truly a part of access to care, how many patient outcomes, how much of a person's recovery or decline, is dictated not by the medicine, but by the logistics and dignity of the journey itself.
That is exactly the question we need to be asking. Keep questioning the hidden systems around you and look closely at who the world is actually built for. We will catch you next time.